Hello, and thank you for joining us for the Wisconsin Parkinson Association's educational video series. I'm Jeremy Otte, Director of Outreach and Education with the Wisconsin Parkinson Association. WPA provides hope, community, support, and resources for people with Parkinson's and their loved ones. Today, we are talking with Dr. Taylor Finseth, a movement disorder specialist with Aurora Neuroscience Innovation Institute in Milwaukee. Dr. Finseth is going to discuss Parkinsonisms and how they are diagnosed. Welcome, Dr. Finseth. Thank you for joining us today.
Thanks for having me, Jeremy.
No problem. You want to give us a little bit of your background and who you are, where you're at, what you do?
Sure. So I'm a neurologist, and I have a specialization in movement disorders and did a fellowship in that area. I practice at St. Luke's Medical Center in Aurora, with Aurora in Milwaukee. And so I help direct the movement disorder program for the entire Aurora system, and also direct our deep brain stimulation program here. I care for patients with Parkinson's disease and other movement disorders and do things like Botox injections. So I've been here in Milwaukee for almost 4 years now, and also part of the Wisconsin Parkinson's Association Medical Advisory Committee.
Great. Well, I appreciate the background, and we're very happy to have you as part of the Medical Advisory Committee. Today, we're going to talk about Parkinsonisms, and I think before we jump into that, I hear at support groups people call it Parkinsonism, Parkinson plus, atypical Parkinson's. Can you maybe touch a little bit on what those what the different meanings of those three terms might be?
Sure. So Parkinsonism is more of an umbrella term for a problem with movement, and it's a syndrome. So what a syndrome is a collection of symptoms or signs that tend to occur together. So Parkinsonism would be defined as something called bradykinesia, and then one additional feature. So that might be stiffness or rest tremor, or a difficulty with balance where you lose your balance backwards. And bradykinesia is a medical term for a type of movement where people move, they tend to move less spontaneously. When they do move, it tends to be smaller movement or slower movement. And often as they move, it gets harder to move. And so that would be, often people might notice smaller steps as they walk, or that they don't have quite as much facial expression, or they might even describe it as weakness, this difficulty moving. And then if you have that plus any of those other features, the stiffness, the rest tremor, or that problem with losing your balance backwards, that is called Parkinsonism. And so that's the name for the syndrome. And then under that umbrella term, there are lots of different causes of Parkinsonism. Those would, I have a diagram here where we have Parkinsonism over here, and then there are then different causes. So there's what's called primary Parkinsonism or secondary Parkinsonism, and we can talk a little bit more about all these features during our talk, but just to get the overview here, within primary Parkinsonism, there's Parkinson's disease, and then there's something called atypical Parkinsonism. And that's also called Parkinson's plus. And then there's 4 main diseases that fall into that category. And so while Parkinson's plus would be a little bit more refined kind of label to put on somebody's clinical problem, rather than Parkinsonism, which is a much more general term and is really just kind of summarizing the patient's symptoms.
And I think that's really helpful because when I talk to people, I think they think Parkinsonism kind of is those atypical Parkinsons. Maybe don't realize that Parkinson's disease is part of Parkinsonism.
Yeah, I think that's a common misconception, and often people, clinicians and doctors only use the term Parkinsonism for patients with atypical Parkinsonism, in terms of when they use that term with patients. But people with Parkinson's disease have Parkinsonism, but the Parkinson's disease would be the diagnosis explaining it. When we see patients with these symptoms, and we decide they do have Parkinsonism, it's kind of a process in terms of trying to get them a more specific diagnosis. And sometimes we are able to say with a fair degree of certainty that it is one disease or the other on that first visit or second visit, but sometimes it takes time to really narrow that down. And it is helpful to have a more specific diagnosis, and that these different diseases have different expectations for how they change over time, or what sort of treatments might be helpful. So we do our best to try and provide the more specific diagnosis, but sometimes we have to stay more general because we're not sure, and start to use the term Parkinsonism.
And I think that's a good segue. You said, we work really hard to differentiate once we have the Parkinsonism. Can you maybe talk within a clinical setting, how do you differentiate between Parkinson's disease and maybe some of these atypical or Parkinson plus symptoms that we may be looking at?
Sure. So, how you might differentiate between, so we'd be here on my chart here, we'd be in the primary Parkinsonism, and we'd be trying to differentiate between Parkinson's disease and atypical Parkinsonism. So we often use, we ask a lot of questions when we see patients, and use the responses to see if they fit with what we expect in Parkinson's disease. So typically, symptoms tend to start on one side more than the other, have kind of a slow progression, and there might be some characteristic non-movement related symptoms like constipation or depression or sleep problems, or acting out dreams at night. And if it fits the typical age for when Parkinson's disease comes on, we'd be leaning towards Parkinson's disease, and then we might decide to try a medication designed to improve some of the symptoms in Parkinson's disease. And if people have a good response to that medication and their symptoms improve, that would also support Parkinson's disease. And then over time, people, the development of what are called motor fluctuations, where people have response to the medication at times of the day and not at other times of the day, or if they develop these extra movements called dyskinesias, those would all be supportive of Parkinson's disease. And so when people aren't fitting that kind of pattern, we start to question that diagnosis and think about Parkinson's plus disorders or atypical Parkinsonism. Another thing that might make us think about those disorders would be what would be called red flags for those disorders. And these vary based on the disorder in question. Within the atypical Parkinsonism category, we have 4 different diseases, and those diseases are have some different manifestations, and so we would be looking for signs of those. So in general, those diseases might be associated with an earlier tendency to fall or have more prominent early balance problems. Some of those disorders are associated with early problems with the automatic nervous system that controls blood pressure or urination, or might have some problems with the ability to move their eyes, or more problems with thinking that come early in the disease. And so that's kind of where that term Parkinson's plus comes from, is that patients with these diseases might in many ways look very similar to somebody with Parkinson's, but plus they have these other problems that are not so typical for Parkinson's disease. And the confusion, there's a lot of subtlety to this, and many of the problems that might point us towards these diseases actually are a part of Parkinson's disease, but they tend to come later and in a less severe fashion. So, somebody listening to this talk might say, oh, well, I have problems controlling my bladder and I was just diagnosed with Parkinson's disease. Well, in these other disorders, it tends to be more severe bladder dysfunction where, the bladder might not work at all. Or so there's a lot of overlap between these syndromes, and so it's not easy to make this distinction, and so would really caution patients away from trying to make that distinction on their own, and really should be talking with their neurologist or movement disorder specialist about that.
I think that's a great point. I think especially a movement disorder specialist who has experience with a variety of movement disorders, not just Parkinson's, would be the person to go to, not watching a video coming in and saying, oh, I have this disease because I saw it on a video.
Sure, yeah.
When you held up your sheet, there's 4 atypical Parkinson's listed.
Yep.
I think I want to touch on, because if anybody's watching it, the one they keep seeing is probably CBD. And I want to make sure that you don't confuse that with CBD oil.
Yes.
So can you touch a little bit on what that is, just so people don't think that it's anything to do with the CBD oil?
Sure. So all these disorders have these 3-letter abbreviations. So there's, so we can talk about CBD first. So that's corticobasal degeneration. And that is a not CBD oil, which is an extract from the cannabis plant. This is a syndrome similar to Parkinson's disease, but is very asymmetric and has a lot of stiffness and problems moving with usually one limb. The dementia with Lewy bodies, or DLB, is also very similar to Parkinson's disease, but tends to have very early cognitive problems. Visual hallucinations are very common, and then some kind of ups and downs from day to day or during the day in terms of their alertness are also common. And then multiple system atrophy would be, you could think of Parkinson's disease, plus a more of a drunk appearance to walking, and then problems with blood pressure regulation and bladder control. And then PSP would be similar to Parkinson's, but have very prominent balance problems early, where people often fall backwards, and over time develop an inability to move the eyes up and down. And so that's a basic overview of the disorders, but there are lots of variations even within those disorders. But as a whole, they often don't respond quite as well to the medication that we use in Parkinson's disease that replaces dopamine. And when I explain Parkinson's disease, I talk about this engine within the brain that controls movement. And when that engine isn't working, it causes that syndrome of Parkinsonism. And in Parkinson's disease, it's more of a problem where the engine runs out of gasoline. And when you give it more gasoline, the engine runs better. Whereas in these other disorders, there's both a gasoline problem and an engine problem where the engine itself is broken. And so often when we replace the gasoline, there's only a mild benefit or there may be no benefit. So they have a lot of overlap in symptoms, but they don't respond the same to medication.
But I think that was a great, I mean, describing the four of them, you really described the Parkinson plus. It's similar Parkinson symptoms, but magnified. I think that's an important thing for people to take away. It doesn't respond to normal treatment, carbidopa, levodopa, like you said, as well. What other treatment options are there if I am diagnosed with one of those four diseases we just talked about?
Sure. Well, we could, go, the different disorders are treated differently. We often would try carbidopa, levodopa, and try some of the medications used for movement in Parkinson's disease, as it can have a benefit. And then we tend to focus on what the most bothersome issue is for the patient. So in PSP, when there's falls or swallowing problems, doing physical therapy and speech therapy, and often patients benefit from the use of a walker, would be some of the treatments available. And then sometimes patients might have issues with their eyes closing involuntarily, where we might use Botox to the eyes, or problems where they have uncontrolled laughter or crying, where there are some medicines approved for that. Whereas in multiple system atrophy, where there's a problem with regulation of blood pressure or the bladder, specific treatments for those problems can help restore quality of life. For dementia with Lewy bodies, because those visual hallucinations and cognitive issues are at the forefront, trying medications that can help with those symptoms would often be a part of that treatment. And then for corticobasal degeneration, it unfortunately is a disease without a lot of medications that benefit it, and often more of a supportive approach is taken with those patients, trying to help them adapt with their other less effective side, and helping with mobility with physical and occupational therapy.
I think that's a good point that you made, is some of the treatment options are non-medical, whether it's physical therapy, occupational therapy, speech therapy. I think that's important, not just in Parkinson plus, but also in Parkinson's disease, that you're looking at all areas, not just pharmacological.
Right. Yeah. I think those are important in any of these diseases, and have been shown time after time again to be very beneficial to patients and families.
I want to go back just a little bit. You had mentioned earlier, when you try to diagnose somebody, it may happen right away. It may take some time. Can you maybe touch on that? Because a lot of people I've talked to who I know who have been diagnosed with PSP or CBD or even Lewy body, it's been 3, 4, 6 years into their treatment that I've been told I have Parkinson's disease and now I have this. Can you maybe explain why that is and what you tell people when that happens?
Sure. So, why that might occur would be that there's often a lot of overlap in terms of the clinical symptoms that people display in these different diseases. When people come to our clinic with Parkinsonism, of these disorders, Parkinson's disease is the most common. It's also the most readily treatable. And so often, you would set out on a course of treating it as Parkinson's disease, unless there were clear red flags of it being another disorder. And some of these signs that would be red flags of these other disorders might not show up for years after the diagnosis. And usually they show up within that first 5 years. And often, in retrospect, you might see that those were more prominent issues to start. But in terms of people actually meeting the criteria for these other disorders, often it takes time for them to develop severe enough either symptoms or signs on their neurologic exam to actually be more certain of these that it's this other disorder. And so I think that that's part of it, in that the progression of the disease, it's often easier to tell the longer somebody's had it. And also that depending on where they're getting their care from, there might be certain providers that are not as familiar of what to look for, so I think it's probably a combination of those two things. But often if somebody has an atypical Parkinsonian disorder, they usually eventually wind up being referred to a movement disorder specialist because they're struggling. These tend to be more severe diseases. And so often the providers that are caring for them are often sort of looking for some assistance because the patients aren't doing as well as they might expect somebody with Parkinson's disease to be doing. They keep going up on their medicine and it doesn't seem to impact their movement, and they keep falling or something like that. So it's a common scenario for patients to either initially get a more generic diagnosis like Parkinsonism, or to be initially diagnosed with Parkinson's disease, and then over time for their diagnosis to transition to one of these other disorders.
And I think what you just shared kind of highlights that there is no foolproof diagnosis yet. There's not a blood test, there's not an MRI. There is something called the DAT scan that has been in use, I think, the last maybe 4 to 5 years. Can you touch on what the DAT scan is supposed to do and what we hope it'll do in the near future?
Sure. So the DAT scan is a nuclear medicine scan where patients would have a CT scan, basically, where they'd lay on a table and they'd take an image of the brain. But beforehand, they would get a medication that binds to a certain area of the brain that is involved in dopamine production. So this is the area that's producing that gasoline for the engine of the brain. And it gets damaged in certain diseases. It would get damaged in all of these disorders that are in the primary Parkinsonism group. So both Parkinson's disease and all 4 of these disorders would have damage to that area of the brain and would be expected to have an abnormal DAT scan. So the DAT scan is not useful in differentiating between these 5 diseases. What it is useful for is if you back up to Parkinsonism, the diseases that are included down here, that either secondary Parkinsonism or some of the things that might mimic Parkinson's disease, these would all be expected to have a normal DAT scan. So the scan is useful in situations where you're considering multiple diagnoses for a patient, and one of them falls up here, or one or multiple of them fall up here, or one or multiple of them fall down here. You would get a binary outcome. It's either a normal scan or an abnormal scan, and it would eliminate the diseases either here or here, depending on that. So let's say somebody came to me with a lot of tremor, and they also had some slowing of their movement in that hand that was tremoring. I wasn't sure if they had Parkinson's disease or, potentially maybe an early form of these disorders, or if they had, something called dystonia or essential tremor. And I wanted to try and narrow that down. And the patient was worried they had Parkinson's disease. That could get us an answer more quickly than just waiting. And so we could do a DAT scan, and let's say it was normal, it would really pretty effectively exclude the possibility of Parkinson's disease or of any of the atypical Parkinsonian disorders. And we would be thinking about the disorders that are more at the bottom of this sheet of paper. And so, it's not a perfect test. It's not specific for Parkinson's disease itself, but it tells us if this area of the brain is damaged, and can help narrow down kind of the list of possibilities.
That was a really good description of DAT scan. I appreciate that. I think you also touched on the one I hear a lot about is essential tremor. I think you touched on how that kind of happens. I think a lot of people confuse that with, they list it as an atypical Parkinsonism, and for you to kind of show that it's more of a secondary or mimic is, I think, very important.
Yeah.
Excellent. I think we've given them a great overview of Parkinson Plus, what Parkinsonism is and isn't. Anything we haven't touched on that you really want to make sure people consider before we wrap up?
Well, I guess I would just like to just touch on the secondary forms of Parkinsonism. So these would be, issues that either directly affect that engine of the brain, but they're not kind of progressive degenerative disorders. So one would be drug-induced, and that is important to recognize. So there are medicines that block dopamine within the brain. So where your brain's still producing that dopamine, or we've referred to it as gasoline, but that can't get to the engine. And it's blocked by those medicines. And those would include what are called antipsychotics, or there are certain antidepressant medications or anti-nausea medicines that can do that. And that would be fully reversible over time if that's recognized and the medications are removed. There's what's called vascular Parkinsonism, and that would be where people have usually the accumulation of small strokes over time in the brain that damage a part of the brain called the white matter, or that engine directly within the brain, that essentially usually cause more of a walking problem that mimics Parkinson's disease with a shuffly walk. And then this normal pressure hydrocephalus is where some fluid builds up on the brain and causes that same area to not work so well. It also tends to present with more of a walking problem. And so those are diagnoses to think about when somebody has kind of a Parkinson's disease-like appearance, but it's mainly confined to the legs. And an MRI of the brain would usually be able to suggest that to you. And then there are some mimics down here that I guess I wouldn't technically define as Parkinsonism, but something called dystonia, which can cause a rest tremor. Something called neuropathy or nerve damage in the legs that can sometimes cause a gait pattern that looks like Parkinson's disease. There's something called essential tremor that usually is more tremor with use of the hands, but over time can develop a rest tremor component to it and look like Parkinson's. And then I just put age on there in that, you know, there often are postural changes with aging and some slowing to walking with generally smaller steps. And they've studied doing these finger tapping tests, which we commonly do to look for Parkinsonism, in that, you know, above a certain age, you know, about 25% of people do have what would typically be classified as abnormal tapping, in that it's slowed and smaller. So, you know, it's a common question that patients come in and are worried that, or questioning, you know, I just thought it was age, you know, that caused my changes to my walking, or ask, is this just age changes? And sometimes that's difficult to sort out, whether it could be mild early Parkinson's disease or whether it could be age-related changes. And sometimes, you know, I'm unable to provide them with kind of the certainty they're looking for there. And so you could either just follow things over time, and if it is a disorder like Parkinson's disease, you know, it's going to tend to have a progressive course to it, whereas you know, aging is a much slower process. Or, you know, even a DAT scan would be a consideration, or a trial medication. So, so you know, but I think we hit on kind of all the other things. I would just want to mention those more common things too.
Well, and I appreciate that. And I think the aging one is an important one. I hear that at my support group all the time, where people are like, oh, you know, this takes longer, that takes longer. I'm like, you know, sometimes it is, we're just getting older. It's not your Parkinson's disease. It is, we're just getting older and things don't work the way they used to.
Right, right.
So, well, Dr. Finseth, thank you so much for your time today, providing information and resources on Parkinsonisms and then Parkinson Plus. While we're all practicing social distancing, please check in with Wisconsin Parkinson Association regularly. We are updating our website and Facebook page with exercise classes, educational videos such as this one, and lots of other resources for you to stay safe at home almost daily. Please email us at mail@wiparkinson.org with future topics you would like to see covered by our local experts. Thank you again to Dr. Finseth for being our guest today. Thanks to you for joining us. Please take care and be well.